For our next panel, I'd like to welcome back Richard Louis to the stage. Thank you, Richard. And joining him will be Edo Benach from Foley Hoag LLP, Amy Lee Overton McCoy from Centers on Aging, University of Arkansas for Medical Sciences, Ali Ahmadi from LE Health, and Sarita Mohanty from the SCAN Foundation. Over to you, Richard.
Thanks a lot, Mel, good morning again to everybody. This one is very interesting, and it was something that I sat down with Mary and I was like, we need to talk about payer codes. As much as I can tell, as soon as I say that, everybody goes, yes, payer codes. We knew that at its very essence, it was an important topic because at the basis of everything we're trying to do, regardless of our background, it does come down to that question, who's paying for what? And so we wanted to dig deep, but also strategically explain to the best of our panelists' ability how that fits into the arc of this ecosystem in the care economy itself. So this session is called Codes, Codes, Codes. You can probably guess what we're going to be talking about, from care to cash flow. And as was mentioned, we have some very esteemed speakers. And I will paraphrase each of their specific points of view. All the way to my right, Sarita is the clinician, also the CEO of SCAN Foundation on the side. Amy Lee Overton McCoy as the provider, as a director at Centers on Aging at the University of Arkansas for Medical Sciences. Ali Ahmadi, the payer, as CEO at LE Health. And then we have Edo Benach, the regulator in one of his past incarnations, now at Foley Hoag as a partner there. So we have the full arc here in that value chain, and we're thinking about how do things get paid for patients and what they're doing. So we have a clinician, a provider, payer, and a regulator, and when they enter a room, what happens? Well, they agree on one thing: nobody is billing for the meeting. All right, that didn't work.
That was a joke.
I really tried. I mean, Mel, I was just, you set the bar, and I couldn't even make it over that. Yeah, I mean, all right, if you want me to repeat that joke, I'll do it at the end, but that was my effort. So let me start with this. I've asked each of our panelists to share something about one code, one payer code. Who is familiar who would say that they are familiar with payer codes in the room? Just raise your hand. Scream out what your favorite payer code is. Just, what's the number? Okay, and what's the payer code number? Okay, anybody? Okay, there you go. What is it? She owned it. Okay. And one on this side. Oh, wow. You're a savant. Anybody else? Okay, great. Oh, yeah, go ahead.
36475. That's a procedure code for surgery.
I love this crowd. Isn't this fun? All right, Sarita, let's make this more fun. Our first slide, talk about your clinician role first, and then talk about the code that you wanted to briefly go over and why, from your perspective as a clinician, and again, you wear many, many hats at SCAN Foundation. Tell us about why that you picked that code.
Sounds good. Well, thank you. This is a really interesting topic for me. As you, in the prior one, you know that I run the SCAN Foundation, but I also am a practicing internal medicine physician. And so the code I picked, and I don't know if we're going to...
We can go to the first slide, please.
Yeah. There we go. Okay. So the code of interest is the Community Health Integration, or CHI, services. And I think this is a really good example as a clinician. First and foremost, I know it's there, but I think like myself and many other clinicians, we get confused sometimes between this code and like some of the Z codes on social determinants of health, et cetera. We are seeing progress, I think, in this code that is really, it's really about care navigation, connecting to community-based organizations. It's really care planning. That's really what the code allows for. And but the challenge is it's still insufficient because one, it's there. I think you have to measure the time it takes for that you offered for that service, and then it has some kind of hierarchy on who codes, but then at the end the physician or nurse practitioner or somebody has to approve, has to be overseeing it. So bottom line is there are challenges with this code. I think and I think there's a lot of need for education. Integration into workflows, and the other concern I'll just add, and then I can pause, is that these codes they're often really integrated into the systems, big health systems, but when you think about the smaller providers like federally qualified health centers, it takes a lot of manpower, education, workflow redesign to implement these. So I worry a little bit about these codes and how there may be some gaps between the big systems versus the little systems.
I'm a patient, you're my doctor, so Dr. Mohanty,
Yeah.
how do you think about codes in that conversation? I come in, you have 15 minutes with me. Are you thinking, okay, first of all, how is this patient doing? What code will, tell me how this all works.
Yeah, so we don't talk about, and one thing Ali reminded me is we also don't know where, as a clinician, 95% you said of clinicians do not even know how they're getting paid, what the workflow of, the flow of dollars is that's ultimately is Medicare, Medicaid, right? So we don't think about codes from that vantage point. We are incentivized, though, to document what we're, all the different, so if I touch on smoking, I gotta make sure it's in my assessment plan. If I touch on, obviously, the clinical, the diabetes, even if just a medication, if somebody's diabetic and I talked about refilling their medication, you gotta put diabetes as part of your plan. So those are the kind of things that we are incentivized to do, but on the back end, then there's all the coding that goes on.
Then they decide what's covered, what may
and
not be
the
covered.
diagnoses, and the problems, the visit diagnoses get coded, right? They're affiliated with a code, but that's.
Do you ever get a feedback, so Dr. Mohanty, this percentage was covered, this percentage was not covered?
Oh no, we don't get that kind of information at all. What we get is you didn't document this. You said it, but you didn't list it as a visit diagnosis, so it didn't get in the code. So make sure you incorporate that. We'll get some of that feedback when they do the audits.
So in a way, they've divided church and state. Journalism, we separate what do we do day to day in news gathering with sales and advertising. It's completely separated.
Yeah, so that's how it works, at least on our. And by the way, they don't teach you anything. Really about anything about codes in medical school. So that
no,
was.
Zero.
Other than just. Make sure you document what you've discussed and your plan with the patient.
Okay, we're going to get on to provider next. Yeah. Do you think that when you go to school, medical school, that you should have one course on payer codes?
I think there should be an awareness in the broader sense of the back end, the business, the systems aspect, because people get thrown into where they go join a practice, and oftentimes they're just really it's more complex than they realized.
Yeah.
They get some of it in the third and fourth year when they're doing rotations, but when you're in the real world, so the answer to your question is yes.
Yes, like film school, in the old days, you wouldn't get a business class, but when you finish your film, what do you have to do with it? You have to sell it to other businesses. It's a similar sort of dynamic that does not only exist in the space we're talking about. Amy Lee is a provider. Tell us about where payer codes fit into the way you think, because you're offering services to all of these patients.
We are offering services, and as a provider, I also am a clinician. And so I wear multiple hats, which allows me to be in the real world on a daily basis. And so there are codes that work better in certain situations and not in the others.
And I know I was supposed to grab the clicker and I didn't. So I'm gonna go grab the clicker and advance the slide for you. That's what happens when I'm so used to having a control room. This control room's great, but they told me that this is it. So this is, let's go to yours. Did I pass it? I'll go back. There we go.
So I could not pick one code because of that. There is not a one-stop encoding. You have to pick what is best and what is available. And in Arkansas, we have about 44% of our state is really rural. Workforce is very limited. And so we do have a lot of nurse practitioners. As I said, I'm a geriatric nurse practitioner with a doctorate in geriatric psychology. So my joke is, don't ask me anything about the other end of the life spectrum. I can't give you that. But we do have some workforce in Arkansas that are community health workers, and because that's what we have available in rural. There's sometimes that first point. And so in primary illness navigation and navigators, we can utilize our RNs, LPNs, community health workers, what we have available. As to where in caregiver training services, we can't. And so we have to really pick what fits best for that situation. And so that's really important to look at your community, your practice, and make it work for the patient, because it is patients.
So with that idea and looking at the codes that you chose, obviously you have no favorites. You love all your children. Just give us an example from each column in 60 seconds as to, and by the way, thank you for the breakdown here.
So in 60 seconds, the primary illness navigator, like I said, you can utilize your ancillary staff. Now, as a clinician and provider, I really enjoy that caregiving training services. But as Sharita said, those clinicians, 15, 17 minutes, it's hard to give that code.
Right.
So maybe doing an incident two, if you are a physician, utilizing your nurse practitioner or your physician assistant and really getting into the caregiving training services. And you can really even do the caregiver training services in group sessions and build that a little bit different.
So do your clinicians, when you're creating your services as a provider for your patients, how much of an input are codes like this to the decisions that you may be making about those services and the way that your clinicians and the way that your nurse practitioners are implementing? How much do they know up and down that space?
So it comes to everybody being at the table and having that open communication, because in geriatrics, it is a team approach. And so it is very important to look at what is that workflow, what's going to work, even to that very front desk, working and looking at what works best for that. And so it is a team approach, but you have to be sure, and we're going to talk about the regulations. There's such as, if you'll notice, consent required. And so that is very important. If you are the clinician, that you're obtaining consent if your team is going to utilize, like the primary illness navigator.
You have several criteria on your rows here. What would you say is the most important criterion when considering the different codes for you as a provider? What tends to be the one that is the focus often when you're debating issues?
First, do you have the staff? Do
Staff.
you have the workforce to implement these codes? And then, of course, we are wanting to be able to maintain services wherever they are. So you also have to look at reimbursement rates and how you're going to be more efficient and effective for the caregiver and the patient.
Are certain codes more difficult to get reimbursement for? And number two, second part of that question is, if it's more difficult to get reimbursement for, does that mean that that particular service doesn't get as much focus? Because then you have to get the patient to pay.
Right, so the consent is important. So if you're not getting the consent, and then you have to document, like on the primary illness navigator, the time spent and what you spend it on, because they have to have a chronic condition that is serious, and you have to state that and document the intervention, those navigations toward that in the 60-minute, 30-minute increments to be sure you're billing. So, for instance, a common problem I was seeing is that people were billing for the additional 30 and never the initial. And so, obviously, it's not going to get paid.
Huh, you're right.
You have to use the right code.
Last question, then we're going to Ali again. But to you on this as a provider, what percentage of the services that you provide have a payer code that's paying for it, roughly?
Gosh, I would say probably 50%.
50-50. Gotcha. Perfect. Thank you so much. Let's go to Ali. As a payer, give us your perspective, and you know where we're going with this here, Ali, and then to your slide on which codes you wanted to share with all of us.
Sure. Same as Dr. Overton McCoy here, I was not able to select just one code. We are a managed care organization delivering 2 of the CMS demonstration models right now through the innovation division of CMS. One is known as the Guide Dementia Model. The other one is known as the IBH model, the Innovation in Behavioral Health. And so we have 9 codes that we pay for. So if your organization is delivering any of these 9, we are a payer that will pay you, and our current footprint is in all 50 states with Guide, and in 47 states with IBH. And so the way this structure has been done is, in Medicaid, there's an abundant amount of home and community-based HCBS services that are done, and during the Biden administration, a RFI was set out specifically to bring additional similar home and community-based services that exist in Medicaid to the traditional Medicare population. And so the way we work is we go out and partner with different types of organizations that we end up becoming the payer for as a MCO. And so mostly when you look at centers of aging across Arkansas as one of our partners, or area agencies on aging, we are distributing Medicare funding down to organizations that under Older Americans Act, under the Veterans Directed Services, VDC organizations, or under Title IIIe, they are already providing 1 out of these 9 care delivery services, and then we're distributing those fundings there. So when you look at code
So there's
aspects,
a code behind every one of these numbers.
so
right?
every single one of these 9 areas has a code behind it. That what's interesting is you don't have to actually be credentialed or licensed as a Medicare provider. We hold all the regulatory compliance and revenue cycle management behind it. But then that's distributing those fundings. So these are the 9 codes that are essentially funded through these demonstration projects.
Why 9? Did you pick 9? It's because the space that your organization as an MCO decided this is the space we're going to exist in, and there are only 9 codes that fit this space.
You're teeing this up for the regulator here. Under CMS, these 9 were part of the initial demonstration project of what's known as Guiding an Improved Dementia Experience. But then you add the IBH, CMS IBH model, and then under number 8, you're seeing the behavioral health therapy and counseling. These are for family caregivers. As you all know, dementia and depression go hand in hand together. And so the innovative care model here was essentially adding behavioral health therapy and counseling for family caregivers, paying it through the Medicare plan of the care recipient. And this is where these 9 codes are. I did not select these. These were, this is what we are.
You were given, basically.
Essentially given.
This is the world of caregiving
It
codes.
started with 7 states.
Yeah.
And now it's expanded to
Right.
all 50 states.
All right, and before we get to these are the codes we give you, Ali, and sorry you have to be that voice, but you will be that voice, Ido. When payers come to you, are you educating them in many cases, well, this is the way this will be paid. These are the codes that will be paid. And there will be those that are more advanced, such as Amy Lee, who knows the codes that they're going to be engaging in. Give me that complexion of those that come to you, and they're very aware of this need and focus on the complexity and layers of caregiving codes?
A lot of the providers, I mean, to actually work, in Arkansas, we're working now statewide through some partners there. In New York, if you look at the CDPAP program, that's a whole other subject and program we could go to. But when you look at the dual eligible population, a lot of funding that's coming down through
What is dual eligible?
these are families or patients that are both on Medicaid and Medicare. Now, they could be aligned duals, which means they're in the same carrier, the same insurance company is operating both their Medicaid and Medicare, or unaligned, or in Medicare Advantage. And so the population that under state Medicaid programs, you would have had a lot of home and community-based services. But what did not exist until 18 months ago was bringing these home and community-based services to families in the traditional Medicare population. And so when you look at the number 9 on respite now, every family in traditional Medicare that's taking care of a loved one with dementia would essentially receive $2,563 of respite stipend to be utilized. And so that's where you see this expanded benefits that are now being done. And you see a lot of demonstration projects that are coming out of CMS now. The buzz right now is the access model, but there's newer demonstration projects coming out, mostly in traditional Medicare.
Got it. Great.
Fee-for-service side.
Fantastic. So as we continue in the value chain here on stage, Ido, biting at the bit here, your time at CMS and talking about codes. All right. So you have the entire value chain on stage.
Okay. All right. So let me kind of start at the very top, because we're talking about risk. The biggest risk inherent in any of this is that a new administration will come in and will have a different opinion about what is or is not in the interest of the American population. And the good news, in a sense, is the previous administration was focused on home and community-based services and equity, and this administration is focused on making America healthy again. It turns out that a lot of the things that make America healthy again involve more care in the community. And so the good thing is, in a sense, that some of these codes and some of these demos that Ali was talking about still exist. They continue, all right? So that's at the very highest level. But there's still, as a regulator, the need to make sure that we manage any risk we have around the dollars. If you're talking about a demonstration like Guide, for example, the risk is that Ali will provide too much payment for too much care. That's Ali's problem. He gets audited because he's the payer. But if you're talking about the providers and whether you're an individual clinician or you're a provider at a center, the risk is that if you provide too much care, Medicare will pay too much money. And therein lies, some of the things on the slide, which is, this is all wonderful. We convinced folks that there should be codes. Now a different part of the agency says, well, wait, hold on. We're going to let you know whether or not these codes are going to be paid for in this instance. Medicare fee-for-service is a pay-and-chase system. You asked before, which codes are easiest to get? Well, they're all easy to get. The question is there a chilling effect as a result of the auditing activity of the agency? And that's where these things come in. So the first thing you look for is medical necessity. You believe that it's medically necessary for someone to provide care. You have to prove it. You have to document it so that an auditor can see whether or not they agree with you. So every code has necessary elements, and we saw it before. Certain codes allow non-physician clinicians to provide those services. Certain ones do not. So it's really important that you have a sense of which is allowed and which is not allowed. So I talked about documentation. Documentation is obviously key. The other thing that's key is getting an individual's consent for that service that you're going to provide.
Which Amy Lee was talking about, right?
That's right. So it's really the top two things. What I would boil all these bullets down and is sort of get into it is, one, document the reason why you're providing the care. Two, convey that to the consumer and to the caregiver out there. And it gets a lot more complex, and as a lawyer, that's part of what I help with.
Help me out. How many elements do the auditors consider? I mean, it's going to vary for sure. Is it like 2,000? Is it 20? Is it 2? Is it 10?
It depends on the code, but the key elements, no, it's closer to a dozen, because you're looking at the site of service, you're looking at the modality of service, you're looking at who provides the service.
Sure.
It's that kind of stuff.
And the auditor, how do they go about this when they're looking at Ali's books?
Well, remember, so it's different for Ali than it is for the provider.
Amy Lee, right.
When they're looking at Ali's books, they're looking at, does he comply with his participation agreement, the thing that's in the demo. That's kind of a relatively simple sort of audit.
And big about the anti-kickback statutes.
Yeah, so they're fraud and abuse, right? Yeah. Is he paying someone in order to get referrals? So there's fraud, there's anti-kickback, there's Stark. It gets complicated there. With providers, I think what they're looking at is, look, we laid out in these codes the rules that you have to abide by in order to sort of provide these services. And and by the way, the auditors are a contractor for the federal government. The federal government's not doing this. A contractor of theirs is doing this. And they're going through, these are the rules, check, 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 and check.
Hey, what's the contractor? Is it a law firm? Is it an auditing firm, like one of the big four?
No, usually it will be, in the first instance, the way that Medicare pays, the way that Medicare fee-for-service pays, is through carriers, fiscal intermediaries. So entities that sit in between the government itself and the folks that are receiving sort of care. And in the second instance, there may be specialty auditing firms that they hire based on specific concerns that they have.
Is this a whole, like, just different sector of this particular value chain here? It's not part of, like, in other words, it's not part of the auditing firms that we are commonly associate with auditing.
But it is a big part of the Medicare program. And so as you're thinking about the opportunities and the excitement about all this, it should be tempered by, it takes money to make sure that you do it the right way and that you're compliant, which gets to Sarita's point, which is the bigger, more sophisticated entities have that money to make sure that they're doing it the right way, and the ones that are less capitalized do not.
How often does CMS hang out with this value chain and say, hey, what do you think, clinician? What do you think, provider? What do you think, payer?
I think, to their credit, in both administrations, both the last one and this one, they do a fair amount of interacting with folks, whether it's in the context of a demo or it's in the context of sort of providers. They certainly do it with the associations that represent them.
My colleagues over at ABC had a great series called I Am a Bill, was one of the things they did. So I Am a Payer Code is something I've been fixated on developing at some point, just because it's so, such a black box. But I want all of you to comment, what do you think is most important to explain in I Am a Bill as I think of producing and writing this thing? And I'll start with Sarita just very quickly. What do you think needs to be in this video?
In the video, well, I think it'll be highly engaging and cartoon-like, like what we learned when we were learning about bills. I actually think what needs to really exist is clarity around what's the incentive. Like, at the end of the day, these payer codes are not really dealing with the core infrastructure. If you're thinking about community infrastructure, home and community-based services, I mean, they're incentivizing activity, right? So we have to be really thoughtful about what these codes are doing and not doing.
And importance level 1 to 10, this will be the same question for all of you. 1 to 10 from where you sit, how important do you think is you better know about payer codes? From 1 to 10, 10 being the most important.
There has to be awareness. I would say make it a 10, just because
for you,
for providers in general, just understanding, and they're telling us we have to document. And I won't even get into the AI, ambient technology, that is now picking up things as you're seeing patients. That is also becoming really relevant.
Can work all sorts of different ways for you as a clinician. Amy Lee, again, provider hat on. What needs to be in I Am a Payer Code, and what's the level of importance you believe from where you sit that folks in your set need to understand payer codes very well?
As far as what needs to be in there as I Am a Code is how to best utilize the right code, not only for the patient, but for that clinical or provider setting. They're not equal. And that's the key. You have to understand what works best. And this is a 10, because if you don't understand it, you will not utilize it correctly. And it's important that they are utilized absolutely correctly back to ensure we're at the regulatory state.
Ollie?
Yeah, to your earlier panel this morning, talking about caregiver support, the infrastructure previously did not exist to get reimbursed for providing services to family members under a specific patient. Now there are codes to do caregiver support education and training. One example, Embodied Labs is currently delivering that and getting reimbursed for it. In the great state of Florida, right now we have in Jacksonville, Linda Levine. These are area agencies on aging that are now getting paid through Medicare. Previously, they were not billing for these codes, but now these infrastructures exist that what they were doing in Title IIIe caregiver support, now they're actually delivering the same services for caregiver support services, but monetizing it through Medicare dollars now. So they're diversifying these. So it's become a 10 now, mainly because a lot of frontline organizations have diversified how they're getting funding through these reimbursements.
And for me, it would be a 10, despite my former regulator and current lawyer hat. It's important to not miss the forest through the trees. This is about getting people care in the community that they need, and ultimately it results in savings to Medicare because you're taking care of unmet needs.
How does 30 seconds to you here? How does a code get created? We heard about these demonstration models. Is that really the core, the 80% of how a code gets created? You get out there in different parts of the country. How does it happen?
No, mostly not. No, actually, I mean, codes get created in a variety of ways through lobbying and activities that that take place all across this town but the exciting thing about some of these demos is that they really allow something that ordinarily would take years and years to manifest itself more quickly, because you're showing, for example, that respite is productive. Real. Yes.
It's called bribery.
So demonstration models are about 20% of where codes come from, where I have 20% input on code output?
Traditionally, yes, or less.
Or less. So there's a lot of, we're at an innovation summit, many businesses are saying, well, how do I get my product or service paid for? And I need a code, basically.
Well, I would say you don't need a code, right? So one of the exciting things about the innovations, be it the new ones that have been announced or the ones that exist, is it's Ollie's risk. He or a Medicare Advantage plan or a PACE provider or a different entity gets to be a little more flexible, sometimes a lot more flexible.
Depending on the code.
Not even depending on the code, depending on what an individual needs, because it's their risk that's at issue.
Ali, so talk to those businesses, those innovators, those founders.
So going back to those 9 codes, that slide, you do not have to be a Medicare provider to get paid under Medicare. If you are providing any of those 9 services that are mentioned here, you can actually get paid. I am the one that has to be a credentialed, licensed, and compliant Medicare payer. So if you are touching caregivers at all, you can get paid through Medicare.
So should they bum rush you here after this panel? They should come to you to get advice.
If you are providing 1 out of these 9 areas of service, you can get paid.
All right. He's a politician, too, in the right town on top of that.
Ido keeps me true here.
Well,
He's helped us a lot.
Amy Lee, advice to founders.
I was just going to say, was particularly like with caregiving, a lot of these educational tools, such as Ollie mentioned, Embodied Labs, can be utilized. Telehealth, so we're teaching a lot, and so if you have something with helping older adults learn technology, or it's all incorporated in, and that's why the workflows are so important, and working with your community so that RNs or your home health is working with and getting payers in, and with your primary illness navigator, you can actually contract some of that and build contracts and have it conducted outside of the provider.
Sarita, final word. What's your advice to founders?
Yeah, I mean, I would say to continue to be really well educated on this. I think, Amy, you offered, and I know there's packets of codes, right, that are existing. I mean,
Packets and packets of
packets
codes.
of codes. So I would say understand them, and then like Amy said, and like the panel said, just make sure that you are, really understanding how the implementation works, how the the education, so that we're utilizing these, and like I think educating all
Yeah.
of you and others about the fact that you can get paid, right?
Yeah.
That's as Ali said.
Thanks to the panelists on codes, codes, codes. And Mary, this is what we were thinking about.
Right.
Everybody has homework now to find your favorite code, right?
Well, yes. So this, in the way we construct this conference, it's often through brainstorming. So Richard and I had a great talk about this, and we iterated it, and then Carrie Shaw introduced us to Amy, who Mel thinks has code red hot shoes, and is filling Sherry Stelling's role with shoes here today. But also, Amy, the fact that you shared that packet of codes, we have packets for all the sponsors at the booth where they could see these codes. And it's really important to get down into the nitty gritty. And then, Ollie, you helped introduce us to, and also you added so much value here. And also the way you're thinking out of the box as an entrepreneur. This is a big lesson in the room. Underline this. Let's get this out into social, because the way you've iterated your own business plan. And Sarita, you always know where we should be focused. So Richard, great job. And
Thank you
great
to
panel.
Ido and Ali and Amy Lee and Sarita. They'll be here, so definitely talk to them about codes. Thank you, Mary.
Yeah, thank you. Okay.